Pulmonary embolism is a really big deal. You're going to see it a lot. There's a high morbidity and mortality associated with it, and it frankly kills people. The problem is that it's a huge topic, and I cannot possibly teach you everything about PE in 20 minutes. So what I'm going to do in this video is give you the MS3 Introduction to Pulmonary Embolism. A lot of emphasis on pathophysiology and diagnosis, a little bit of touching on treatment. If what you want is an advanced discussion of treatment and the diagnostic algorithm, check out the intern videos for more information. And even that's not going to cut it, so you're going to probably have to go to a reference book in order to learn pulmonary embolism in its entirety. Now, when someone says pulmonary embolism, they could mean a lot of things. They could mean the cholesterol emboli from a broken leg. They could mean placental contents from a bad delivery. They could mean air emboli from a bot central line. Or they could imply an infective endocarditis and embolizing bacteria. But what we mean when we say PE is really VTE, the venothromboembolism, the clot that starts in the deep veins of the legs and ends up in the lung. So let's start by talking about DVT because they are essentially one contiguous disease. DVT is a clot in the deep veins. The person has got some arms. Let's give him a big chest because we're going to draw some stuff in there. He's got a good leg, a heart, lungs behind it, and then some veins coming in from the rest of the body. Now what we're talking about is a clot that forms in the deep veins. And that is a deep vein thrombosis. The way this happens is by Virchow's triad. You must have these things in order to develop a deep vein thrombosis. The first is venous stasis. These are hospitalized patients. The patients who stay in bed for long periods of time or who are post-operative, who don't get up and move around. Board favorites are also going to be the people who take long car rides or people who have been on planes and don't exercise their calf muscles. The second part of Virchow's triad is going to be endothelial injury. We do this in the hospital by placing central lines. Any plastic increases the risk of thrombosis, but endothelial injury can happen also simply by smoking. The third thing is a hypercoagulable state. This may be in the form of hormone replacement therapy, oral contraceptives, factor V Leiden, or malignancy, something that makes them more likely to clot. You have all these three things, a clot forms. Now the problem is that the veins continue, but the fluid from the leg can't get out. So where it ends up is in the extremity itself. In this case, it's a leg. So what you're going to see distal to the clot is edema. And that is the patient presentation. Unilateral leg swelling. People learn about the Hammond sign, and I hear it spoken a lot. Unlearn that. Calf tenderness has no impact on DVT. Positive and likelihood ratio of 1, which means it is useless. Instead, what you should be looking for is a difference between extremities, 2 centimeters greater, 2 centimeters below the tibial tuberosity. That is, one leg is bigger than the other by 2 centimeters, suspected DVT. DVTs are diagnosed by ultrasound, and when you find one, you anticoagulate. We're going to talk more about anticoagulation when we talk about treatment for PE. So this was a DVT. What we want to talk about now is a pulmonary embolism, that this clot that breaks off, travels to the lung, and gets stuck. And that happens because the caliber of veins gets bigger the more proximal you get. And there are no valves, so the clot just travels, gets into the right ventricle and then into pulmonary arteries. And subsequently, the pulmonary arteries get smaller and smaller until they're capillaries, which means that the clot will be trapped in the lung. To explain the pathology, what happens, I'm going to use two models, the lung itself and the alveolar capillary membrane. I'm going to use two examples to draw out all the pathology. What could happen is that a really big pulmonary embolism obstructs the pulmonary blood flow and causes a wedge infarct. Now, the pulmonary system has dual blood supply, so it's hard to cause a wedge infarct. But if you get one, what you'll find is that the necrosis, the dead lung, leads to hemoptysis. Because it can involve the pleura, and the pleura has sensation, ischemia of the pleura causes a pleuritic chest pain. And now, the right heart, which is used to a low pressure system without a lot of resistance, all of a sudden has a boulder in the way of flow. That's going to increase the resistance and increase the pressure the right heart has to deal with. This leads to pulmonary hypertension, which can produce right heart strain. But the big issue with the actual clot in the blood vessel is this. No blood can get in. That is a 0% perfusion. Gas can exchange, no problem. CO2 out, O2 in. But there's no blood flow. So there's 100% ventilation. That is a VQ mismatch. And this is going to lead to hypoxemia. But PEs do more than that, because big PEs can kill people, but the size of the PE doesn't do anything, doesn't mean anything. It's the body's response to the clot. Size is irrelevant, location is irrelevant, because it has to do with platelet-derived mediators. Effectively, this causes vasodilation and allows fluid to leak out, which causes a larger diffusion barrier for oxygen. Now, without getting into too much physiology, you can feel that oxygen traveling this distance is easier than traveling this distance. With a bigger diffusion barrier, less oxygen gets in. Oxygen is diffusion limited, such that barriers to diffusion, such as an increased wall thickness, will prevent oxygen from getting in. So oxygens fall, thus the hypoxemia. Carbon dioxide, on the other hand, is perfusion limited. You can make the diffusion barrier as big as you want. At livable levels, CO2 is going to get out. What does that mean? Delivery of oxygen is based on the hemoglobin times the percent sat times the cardiac output. And the cardiac output is stroke volume times heart rate. When someone suffers a PE, their percent sat is going to go down. The oxygen levels will fall. The body can respond in one of two ways. It could increase hemoglobin or increase cardiac output. But hemoglobin takes too long to respond to hypoxemia of an acute PE. So what happens is the cardiac output goes up. This happens in the way of the stroke volume and the heart rate. So you're going to get tachycardia and likely tachypnea because your oxygen levels are low. CO2 is perfusion limited. So with tachycardia, increased perfusion, and tachypnea, increased ventilation, you're going to drop the CO2. And because the CO2 drops, the pH will rise. All of these are sort of soft signs because they don't have to happen, And they may happen, but they may not happen. So none of these are really reliable for pulmonary embolism, but these are the potential consequences of having a PE. And as you begin working up PE, you might go to the shortness of breath workup, chest x-ray, EKG, ABG. Well, we know already the results of the ABG. It is a hypoxemic, hypocapnic respiratory alkalosis. But lots of things cause that, not just PE. The chest x-ray is usually normal, unless you have a wedge infarct, in which case you can see it on chest x-ray. You're going to have a normal EKG. And if you have an EKG, you might see an S1, Q3, T3, which is indicative of right heart strain. We'll talk more about that in the advanced videos in the intern content, because right heart strain is treated a little differently than a normal PE. But for you, what do? ABG, chest x-ray, EKG doesn't work. I'm thinking this person has a PE. Well, if you have signs and symptoms of a pulmonary embolism, what you're going to do is ask, what is the pretest probability that this person has a pulmonary embolism? And the way you do that is by using the Wells criteria. You do not have to calculate the Wells criteria on the test, but you will all the time on the wards. It's worth having them in your pocket so that you can refer to them time to time when you're on medicine. If your pretest probability is low, that is, your Wells score is less than 2, this is probably not a PE. What you do is get a D-dimer. When the D-dimer is low, you say, aha, I'm right, I don't have to worry about PE. The problem in real life is that D-dimers elevate for a lot more reasons than blood clots. So if you have someone who's acutely ill or has some inflammatory problem, a D-dimer might be elevated. So you only get a D-dimer when your pretest probability is low, you don't think it's a PE, and you just want to reassure yourself and the patient that it's not. If, on the other hand, the probability is high, and that's greater than or equal to 4 when you're considering a CT scan, or greater than 6 when you're considering a VQ scan, then you have a high pretest probability. If that probability is high, you want to definitively diagnose it. And there's 2 ways to do that. The first is with the CT angiogram, also called a spiral CT, also called a CT scan with PE protocol. But it's a CT scan with IV contrast. It is the best test to do. That's what you want to get when you say, I think this person has a PE, get the scan. But because it has contrast, they must have normal kidneys. Because if their creatinine is elevated, they can't get the contrast. So if you think this person has a PE, they can't get the CT scan, you instead can use the VQ. A VQ scan can be used with abnormal kidneys, but requires there be a normal chest x-ray. You compare inhaled isotopes versus injected. If anything gets in the way of you viewing where that gas goes or where the blood is perfused to, you can't use the test. So it must be a normal chest x-ray, but can be used at abnormal kidneys. Now, I said CT is the best test. Theoretically, the pulmonary angiogram is the gold standard. You will not pick pulmonary angiogram on your test. The reason is that it is invasive and requires IV contrast and is not that much better than the CT angiogram. It has its uses, generally in chronic thromboembolic pulmonary hypertension. Check out the intern videos on PE. But for the workup of an acute PE, pulmonary angiogram is not used. I'm lying to you a little bit to keep it simple. But remember, not used. Once you diagnose the PE, how do you treat it? The treatment is with anticoagulation. What does anticoagulation mean? Traditionally, it meant heparin, warfarin. And you bridge. Warfarin blocks 2, 7, 9, and 10, as well as protein CNS. If you initiate warfarin without any other anticoagulation, CNS disappear first and the person becomes hypercoagulable and whatever clot they have worsens. So do not start warfarin without first bridging with a heparin product. Now whether you use a heparin drip or low molecular weight heparin is a little advanced. You should only have to pick heparin. Know now that low molecular weight heparin has taken over the heparin drip. You bridge heparin to warfarin for 5 days or until the INR is 2 to 3, whichever is longer. You could also use one of the novel oral anticoagulants. Dabigatran, apixaban, or viroxaban, doesn't matter which one you pick. These do not need to be bridged, and you don't have to monitor an INR. In the acute setting, you should be giving a heparin product. There's some other ways to treat venous thromboembolism other than with anticoagulation, though. You could use an IVC filter. Don't use an IVC filter. There have one indication. An IVC filter is placed in the setting of a DVT where the next pulmonary embolism would kill that person, and there is a contraindication to anticoagulation, which means bleeding. So for your vignette, GI bleed and a DVT, put in the filter. But as soon as the bleeding risk is removed, the filter comes out and they go on anticoagulation. In general, IVC filter for venous thromboembolism is the wrong answer. There's also TPA, the clot buster. TPA is used in a massive pulmonary embolism. That is, you have pulmonary embolism and hypotension. Give TPA. Otherwise, it is heparin to Coumadin bridge or novel oral anticoagulants. One last caveat, if you have metastatic cancer, you're going to die soon. Don't get put on warfarin or new oral anticoagulants. Just use low molecular weight heparin for the rest of your life. That's PE.